Hey guys, welcome back. We're going to be talking today about rhythms that are originating from the atria. As opposed to last time, we were talking about rhythms originating from the SA node. Alright, let me draw my electrical conduction system. Remember, all cardiac myocytes have the ability to generate its own electrical impulse. They don't, usually, because if they do, then we have chaos, and we don't want chaos. We want a nice organized rhythm, so that's why the SA node is our primary pacemaker. So when we talk about the heart being able to generate its own electrical impulse, we talk about it having the property of automaticity. Classic test question, all right? Only cardiac cells have that. It's because of this unique cardiac property of automaticity that every single cardiac myocyte, no matter where it's at, can generate its own electrical impulse. If one of these atrial myocytes decides it wants to throw a beat and then assume primary pacemaker role, then we have a dysrhythmia of the atrium if it continues to beat over and over and over again. Either one of them can beat over and over and over again and be the primary pacemaker, or different ones can beat at different times, and we'll go over rhythms that you'll actually see that. So when we talk about atrial dysrhythmias, we talk about rhythms that are actually originating somewhere in the atrium outside of my normal electrical conduction pathway. When I'm looking at my EKG, one thing I'm going to notice is that I'm going to have upright P waves because the impulse is still traveling down towards my positive electrode in lead 2. Remember, electricity flowing towards this positive electrode are going to present up on an EKG. So I'm still going to have positive P waves, but they're not going to be nice, rounded, and upright like you would see in an SA nodal P wave. They're going to be kind of peaked almost, or they're going to look different in morphology. You have that P mitrale look, or a biphasic P maybe. So that's what we're looking at, are these P waves. That's going to distinguish maybe an atrial P wave from an SA nodal P wave. Now let's take some examples of what I'm actually talking about here, okay? Now when we go over these rhythms, remember, always use your rules. Never forget your rules of what makes a normal sinus rhythm actually normal. Remember, you're looking at your P wave. You have to have a P wave before every QRS complex. Your QRS complex has to be between or has to be less than 0.12 seconds. In some books, you might have it read between 0.04 and 0.12. Your PRI, your PR interval, has to be between 0.12 and 0.20 seconds. Your R to R intervals have to be normal, meaning that all your distance between each R wave walks out. Your P to P intervals have to walk out, and your rate has to be below 100 beats per minute. You have all that, right? You have your normal sinus rhythm. Important. So when we look at this one, this is our first rhythm, or our first arrhythmia of the atrium, is called wandering atrial pacemaker. And you can kind of put two and two together and try to kind of see what's actually happening with this rhythm. Wandering atrial pacemaker. Well, that's just it. You have different atrial ectopics. And by ectopic, I mean somewhere outside of the norm. You have different atrial ectopics beating per beat. So you might have this one little guy here, this little guy beat a couple times, and this one beats a couple times, then that one beats a couple times, and they kind of pass the buck. That's a wandering atrial pacemaker. The normal pacemaker is wandering from ectopic to ectopic, and we're going to see that on an EKG. Now the rhythm might be slightly irregular, nothing too crazy, but that's just it. The pacemaker moves from the SA node to various areas, and when we see this, we got to look at our P waves, because we notice that this P wave is different from that P wave. That looks different from that. That looks different from that. That looks different from that. So you have at least 3 different P waves. If you have 3 different P waves, let me rewrite that, 3 different P waves in an otherwise normal looking rhythm, Well, you have wandering atrial pacemaker. It's that simple. Your R to Rs might be slightly irregular. My P to Ps might differ. And I'm going to have 3 different size P waves. And your rate is going to be less than 100. If you have all of that, you have a wandering atrial pacemaker. There's nothing too much to say more about that. As far as treatment's concerned in the field, we really don't treat wandering atrial pacemakers. It's pretty benign. If something were to go wrong with the wandering atrial pacemaker, and we're talking about a tachycardia, it's no longer wandering atrial pacemaker, and we would treat that patient just like we would any other tachycardic patient. All right? So the next rhythm we're going to go over is a PAC. Now, a PAC generally or technically isn't a rhythm. It's one beat. And we're going to see that beat right here that I'm circling with my marker right here. A PAC is exactly what the word says. It's premature, which means that this beat is going to come before you would expect your next rhythm to be, or your next beat to be. So if you would look at this rhythm, you would see an otherwise normal, regular rhythm. The R to Rs walk out. And if I were to take this extra beat here and move this slightly over to the right, that would be right where you would expect it to be. So a premature beat is going to come a little bit before you're expecting the next beat to come. Also, you're going to look for a P wave. You see a P wave there. It looks a little different. Excuse me. But if you see that P wave, then you know that it's an atrial contraction. We know it's premature because it's coming before when you would expect it to be. And we know it's atrial because we have a P wave. If we saw this exact beat and there was no P wave or it was inverted, it wouldn't be an atrial complex, all right? It would be a junctional complex. But we see a P wave. This comes a little bit before than you would expect it to. So it's atrial and it's a contraction. We all know that. So that's deemed a PAC. A PAC isn't a rhythm. It's beats within the rhythm. This is an otherwise underlying normal sinus rhythm with a PAC. That's how you would write that down. All right. And that is just because of you have a normally beating sinus rhythm, but every now and then one little atrial ectopic decides to fire, sending the electricity down before you would normally expect the next SA nodal contraction to happen, and you would get that PAC. Again, treatment's not usually indicated. These are the patients that have like a little flutter in their chest. You might feel their heart skip a beat. Patients get this a lot when they drink coffee or early in the morning when they smoke a cigarette. So we really don't treat those patients, but we do have to diagnose those on our EKGs. All right. Now this brings us to SVT, or our supraventricular tachycardias. And again, SVT is not technically a rhythm. It's a wastebasket of rhythms. If I have a tachycardia T that's fast, really fast, and it's happening somewhere above the ventricles, then I call it supraventricular tachycardia, meaning above the area of the ventricles. The pacemaker site is above the ventricles. Now, I don't like this heart rate must be at least 150, all right? Well, where that comes from is a misnomer, all right? I hear medics all to say, well, in order for it to be SVT, it has to be above 150, or 150 means that it's SVT. Well, no, it doesn't. Remember, the fastest that your SA node can go, all right, is our target heart rate, in which we would do 220 minus our age in years, right? So you do 220. I'm 31 years old. So 220 minus 31 would be what? 189. So technically, I can have a sinus tachycardia at 189. My SA node can fire at 189 beats a minute if I use that equation. Meaning that if I look at an EKG and the heart rate's 180, and I can see P waves, they're upright and rounded, it might be a sinus tachycardia. It might be. Now, atrial tachycardias are usually a lot faster, above 200 with a notched P wave, but we're not going to really be able to see that because the rhythm is beating too fast. Now, if we look down here and we see this rhythm, we notice that we have an R, S, and then we have a T, or what's presumed to be a T. And I get questions all the time. I say, well, how do I know that's not a P? How do I know that that's a P and not a T? Or how do I know that the P wave is not within that T wave? Well, we really don't. We really don't. So we call this SVT because it's going so fast that we're not able to tell where the rhythm is originating from. All right. So our whole treatment in treating SVT is to try to slow the rhythm down enough to try to see where the rhythm is originating from. If I got upright rounded P waves, it's probably a sinus tach. If it's got peaked P waves, then it's probably an atrial tach. If it's got inverted P's or no P's or retrograde P's that are inverted, it might be a junctional tach. All right, but that is our whole goal of treating SVT, is slowing the rhythm down enough in order to see where it's coming from. If I have a rhythm that I cannot tell P waves at, you cannot tell if it's got P waves or not. It's beating so fast. Usually above 150, because that's how fast it needs to go in order for you to hide the P wave. So you have a non-existent PRI. You just call it SVT. It is a supraventricular tachycardia until you can prove what rhythm it is. These are the patients that we cardiovert. These are the patients that we give adenosine to. We can give a trial of cardizem. We might be able to give some procanamide or amiodarone. Or the new ACLS guidelines, we can give sotalol or a beta blocker. These are the patients that we can do that to slow this rhythm down. Once this rhythm slows down, then we can give it a name. We can give it a real diagnostic name. But that's what SVT is. Normal R to R intervals, usually, we're not going to be able to see P waves. And because we can't see P waves, we're not going to be able to see a PRI. And the rate is usually going to be above 150. If we can't tell where the rhythm's coming from, we call it an SVT. All right? Which brings it on to our next one, MAT. MAT, or multifocal atrial tachycardia. Now, MAP pretty much equals WAP. Multifocal atrial tachycardia usually looks like a fast wandering atrial pacemaker. All right? Multifocal atrial tachycardia looks like wandering atrial pacemaker, except MAT is going to be greater than 100. Why? Because it's a tachycardia. Well, look at my rhythm. We still have the pacemaker moving within the atrium, just like wandering atrial pacemaker does. It's going to be irregular, kind of just like wandering atrial pacemaker does. And it's irregular because I have an ectopic beat in the atrium that's moving around. And depending on the distance from my AV node is how long my PRI is going to be. If it's close, then it's going to be a short PRI. If it's far away, it's going to be a longer PRI. Right? But my P waves are going to look different. I got a tall P wave here, almost non-existent one there. That one looks different. And again, I have different looking P waves. I have at least 3 different P wave morphologies. Greater than 100, irregular, multifocal atrial tachycardia. It's not Afib because there's no fibrillation waves. In Afib, I have this fibrillation wave here. I don't have any discernible P waves, and I have an irregular QRS complex. On here, I have discernible P waves. They're right there. I can see them. And there's no fibrillation waves. So I can call that MAT, or multifocal atrial tachycardia, because it's a lot like WAP, wandering atrial pacemaker, except that the rate is above 100. Pretty simple, huh? Which brings me on to A flutter. A flutter has a characteristic pattern. And it's one of those rhythms that you can kind of look at and you can pretty much make a diagnosis of what the rhythm actually is just based on the appearance. Again, that is bad form. We want to go through all of our rules when talking or when trying to diagnose these rhythms. But atrial flutter has these classic sawtooth waves. They kind of look like shark fins or teeth of a saw, thus being called sawtooth. We call those F waves. They're no longer P waves. We call them F waves. So when we look at this rhythm, we're going to have a QRS and then a flutter wave, QRS, flutter, 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 QRS, flutter, flutter, flutter. It's in a pattern. So we would call this an A flutter with a 3-to-1 response. That's an A flutter with a 3-to-1 response because they have 3 flutter waves for every QRS complex. I can have a 4-to-1 response. I can have a 2-to-1 or a 1-to-1. I can even have a variable response, meaning that there's 3 here, 2 here, there might be 3 here and 1 here. All right? But this is a flutter. Almost normal R to R intervals. That all depends on whether or not this is variable. If it's not variable and it's a fixed 4-to-1, 2-to-1, I'm going to have a normal R to R interval with flutter waves. I have a almost 1, 2, 3, 4, 5, 6, 7, 8, a rate of 80, almost normal. But I have a 3, 6, 9, 12, 15, 18, 21, 20, almost a 230 beat per minute atrial rate and an 80 beat per minute ventricular rate. Those atrium are kicking a lot faster than my ventricles are, which means I have atrium firing really fast, but almost every third goes down, or every fourth goes down to the ventricles, to depolarize the ventricles. This can degrade into Afib, and we treat A flutter and Afib the same way. We can treat them with our medication, we can treat them with our cardism, or we can treat them with our electrical cardioversion. It all depends on how stable my patient is. Unstable patients will get electricity. Stable patients will get a trial of medication before we pop them with electricity. But that is all dependent on you doing your assessment and trying to figure out what would benefit your patient the most. All right? And that is A flutter. And on to our last one. Afib, the classic atrial fibrillation. We call them Afib. All right? Now, this is the equivalent of VFib, but in the atrium. Your atrium here aren't depolarizing normally. You have a whole bunch of different atrial ectopics just firing on their own. And by all of this disorganized chaos, your atrium is just kind of flopping around like a fish. It's not really contracting, it's just fibrillating. And every now and then, an electrical impulse will go down to the ventricles. It does it very irregularly. And Afib is the only rhythm that we talk about, which is irregular. There is no rhyme or reason. So when you look at your EKG here, you're going to notice that you have no discernible P waves. This almost looks like artifact on your isoelectric line. It's flopping all around. And if I were to actually take out these QRS complexes, it would almost look like VFib. So I have fibrillation waves, and my R to R intervals vary between each one. People live every day with Afib. It's when it happens acutely, or your Afib gets with a rate of over 100, in which you start having problems. Afib with a rate of over 100 we can call RVR, rapid ventricular response, or we can also call it uncontrolled Afib. Those are the patients we want to treat, but there's a reason we don't want to treat them if it's been going on for greater than 24 hours. So when you're assessing your patient and you say, sir, ma'am, when did all these symptoms start? And they say 2 days ago. We don't want to treat them with medications. We don't want to convert their Afib. This fibrillation here is not allowing for adequate blood flow. So we might have some clots building up. And if all of a sudden we increase cardiac output by causing this Afib to convert into a sinus rhythm, they might push through these clots and cause a stroke. And we don't want that. Or cause a bleed or a heart attack, which we don't want. Or cause a PE. It all depends on where the clot lodges itself at. And that's not what we want. So greater than 24 hours, some books might say 48 hours. Again, it all depends on your protocol. You don't want to treat your Afib. In the acute setting, though, we do want to treat our Afib. That's where we do our, again, cardioversion, our cardism, amiodarone, whatever calcium channel blocker your department carries. But those are the rules for Afib. It's going to look like an irregular rhythm, irregularly irregular, with fibrillation waves instead of your P waves. No discernible P waves. All right? Well, that's it for the atrium. Our next EKG podcast, we're going to talk about AV node rhythms or AV junction rhythms, which are pretty easy and they're pretty cool. So stay tuned. See ya.